Did you say yellow?
I said yellow. Okay, welcome. Hello everyone. I'm Dalia and this is obviously Dr. Jordan Fagenbaum, also known as Jordan from Barbell Medicine.
Jordan Barbell Medicine, that's right.
I think you go by your first name sometimes.
I would prefer Jordan, yes.
Jordan, okay.
Yeah, yes.
Thank you so much for being here.
Yeah, thanks for having me.
He came to Dubai as a surprise for me. I think you already knew that you were coming. He was kind enough to answer some of my questions. We're just going to have a little bit of a chat. And that's basically it. You want to say anything first? Introduce yourself.
Oh, sure. Yeah, Dr. Jordan Fagenbaum from Barbell Medicine. I am in Dubai. This is on location.
Yes.
This is great.
Yeah.
At Desert Barbell. And I'm glad we got to meet and got to do this. Yeah. So
I actually messaged him, was it like a year ago?
Oh, okay, originally, yeah.
Yeah, like we were supposed to do this online, but I was in Lebanon at the time and all of that was happening.
She ghosted me. That's what
I ghosted him basically, but then he just popped up in my gym. He was like, hey, you ghosted me.
Yeah, what's up? Yeah, that's what happens. That's exactly you ghost me in the DMs, I'm showing up.
Yeah, that's basically what happened. Okay, so if anyone has watched my old video about how I actually got into lifting, I do mention you. I mention Austin Baraki, I mention Alan Thrall.
Cool.
So I had like really bad back pain for 4 years and then knee pain for 2 years, and it's your content that got me out of that and into lifting. So I'm forever grateful for that. And I'm sure so many other people have had this kind of success story and how much your content has helped them kind of get out of pain. So if anyone also doesn't know Jordan, you should follow them on YouTube, on Instagram, and all of that.
Sure. And
kind of absorb all of that information. So speaking about injuries, we're going to talk about that to begin with. Okay. We know that injury is not something that you can originally kind of like prevent. Mm-hmm. You can manage it, you can manage your load, you can manage fatigue, you can manage all of those factors. But at the end of the day, pain does happen. So if someone feels a little bit of like an icky pain somewhere in their shoulder, in their knee, in their hip, what would you advise them to do to begin with? Like if it hasn't gone for like 2 weeks, a month, 3 weeks, they're just starting to feel pain.
Yeah.
What would they do?
No, I think that you made an excellent point. A lot of the like prevention versus risk reduction, like it's just a nomenclature thing, but can be almost just semantics, right? Because like you're right in that we can't really prevent it. It's going to happen. It's part of the human experience is having pain. As far as injuries go, yeah, we kind of view it as like we can't prevent all of them from happening. We would just like to reduce the incidence, reduce the duration, and then also have a game plan for what happens then. And then, so I think the second thing is being able to differentiate between, okay, what is a pain that probably needs sort of intervention, and what is a pain that's just kind of like you're active and it kind of happens. And I think that comes with experience, right? You might be, for example, squatting, and you're like, my knee it's a little sensitive, or it's just not feeling 100%, or I'm aware that I have a knee right now when I'm not normally. That stuff probably doesn't require any specific management. More so just instead of ignoring it, that's not the advice. The advice is saying you can verbalize, my knee doesn't feel great right now, but otherwise not being hyper vigilant, not paying attention to it as much and focusing on it during the rep, because you can make yourself more aware by paying direct attention to it and almost have a more intense experience. But yeah, if the pain is, again, this comes with experience, if it's not terribly serious, I wouldn't recommend doing anything. But you're right, if it's either severe, acute, and like making itself known without you paying a bunch of attention to it, or it's been persistent, the chronicity is longer. At that point, we're trying to change the training load in a way that makes the movement pattern or movement patterns more accessible to you in an effort to get back to unrestricted movement, right? Because basically what you're saying is this pain is so significant, it's persisted so long that I'm unable to participate in all the activities, all the movement patterns, all the things that I want to, without it severely hampering not only my performance, but just enjoyment, and then also progress. The whole thing, yeah. So for example, on a squat, if you have knee pain and it's preventing you from hitting depth, preventing you from using the loads or around where you should be, and this and the other, that probably requires some intervention. And what we're trying to do is use a type of movement that it desensitizes you, but also is the most sort of threatening movement that you can tolerate. So if we consider like squat with no particular tempo, just your volitional tempo, descent speed, ascent speed, and loading and rep scheme, if all of that is like the what we're trying to get back to, you can pull one or more of those levers to try to desensitize yourself without really wholesale changing the movement. So first thing, and this is the thing that people probably screw up the most, is loading. Yeah, because a person will be like, oh, I squat 250, that's my 1RM. And they're like, so today I'm gonna squat 240. I'm like, that's probably not enough of a load reduction. And so the way we kind of force people to do that is instead of doing 3s or 5s, now we're doing 10s or 12s. And it's like, well, you have to take weight off the bar.
Yeah.
And so at that point, you're preserving the range of motion, you're preserving the same movement pattern, and if that sort of is an entry point for you to do the movement without being sensitized, great. If that doesn't work, then the next thing we're probably addressing is tempo. So now we're doing, instead of 10s at a normal volitional tempo, we're doing 10s at a 303 tempo, or 530 tempo, or it's 3-count pause. Again, we're just taking load off the bar in an effort to desensitize you in the movement pattern that you want. And then if that doesn't work, then we can start, yeah, you can do range of motion, you can change positioning. This is probably most applicable in things like the bench press. So if you're like, I'm having shoulder or elbow pain, it's like, but I can adjust my grip in or out and be desensitized. That's where we're gonna start. On the squat, it would be more like, we're gonna switch from low bar to high bar, or low bar to safety squat bar, or to front squats, or whatever. And so again, you're preserving the general movement pattern. It's just a little bit different, and can be not only just changes the load, but also any sort of overuse injury, if that's kind of the origin, we'll say, of the pain experience, you're getting away from that. So yeah, range of motion, tempo, and then kind of small changes in the movement pattern versus if with the bars placed, implement use, whatever. That's all of the things we would try initially. And then if none of those things work, then you start moving further and further away from your target movement.
Press, hack squat, something like that.
Exactly. You could get all the way to like, we're gonna do a wall sit, like an isometric wall sit, or in a deadlift, just like body weight hinges, things of that nature, or single leg RDLs. And it's just, yes, the further you have to start away, the path becomes a little longer for you to get back to that unrestricted movement.
If you're pain-free, then it's worth it.
Yeah, 100%, and then you gotta start somewhere.
Yeah.
So just where you start doesn't really tell me how long the thing's gonna take. The point is that we find the entry point where you are pain-free or it's tolerable, and then you can start your progression. But if you never get to that entry point, I don't know where your progression starts. Yeah. And so instead of something lasting for 8 weeks, 10 weeks, 12 weeks, I'd prefer it to last 2 weeks, 3 weeks, even 1 week. So yeah, that's where I would have people start. We have this in our article, Pain and Training, What Do. It's like, find your entry point. And if you were using like a pain scale, like a RP, like similar to an RP scale, I would want somebody's pain to be, 3 or less with whatever movement you're starting at. The real point is to break the cycle. So if, for example, you've been squatting every time you've had knee pain for the last week or 2 weeks, 3 weeks, it's like, we need to stop that today. Not like you have some pain, almost no pain is where I would prefer people start. And yeah, again, you would try to have the movement be the most similar to what you're trying to do, but again, without that pain experience. And I think finding the entry point, that's first most important thing, and then the progression from there is kind of a choose your own adventure. There are many different ways, all roads lead to Rome, but again, I find that people, particularly powerlifters, they're very highly motivated. In general, injuries creep up when people are loading things real heavy, and that can be discouraging to move away from that, so they'll try to progress back almost too fast, and it's like, just let's give yourself a little runway here, build some capacity, desensitize you, and then yeah. So I think my personal preference on this is, if you've had to adjust tempo, that's the first lever I'm going to move back to normal. So if it's 303 squat, do that for a week or two. Probably I would err towards 2 weeks. Then let's go back to normal tempo, keep the higher rep scheme, again, to control load. Then after that, you're going to start slowly titrate the rep scheme down back to what you are normally doing. And again, the further away you start, yeah, you're just going to have to take incremental steps. But it's never like, all right, yeah, I did 10s tempo for a week, now I feel okay, let's do singles.
Yeah.
But people do that, right? Because they're like, well, if I can just...
Feel fine now, let's just go back into it. Yeah.
Exactly. And it's the last part I'll say, so we talked about entry point, progression. The third thing is that I think a problem people have when they sort of do this rehab phase, they view it as like very different than their normal training. And so I would almost push back against that and say the total training load, the training stress you're exposing yourself to, I want it to be about the same as your normal training. It's just going to be different.
intensity-wise and volume-wise?
Yeah, so if you have your external training load, which is like all the nuts and bolts of the program, so volume, average intensity, movement selection, rest periods, etc., that gets applied to the individual, all the unique factors that make them, ultimately take that training stimulus and you get a resultant training stress. And you can rate that with RPE, session RPE, rating of fatigue, whatever you want. I think that training stress, which we call internal load, should be about the same. You may accumulate that via leg press, via tempo squats, whatever. Yeah, exactly. But the total, that kind of training stress should probably not change that much from what it was before. If we have a hunch that the training stress was far too high, and the reasons why you may think that is, I just ramped up my volume a bunch, or I ramped up my average intensity, or my training didn't actually change that much, but my life stressors went up. My sleep was poor, exams at school, interpersonal stress, whatever.
There's just under-recovered more than actually overtrained.
Yeah, you've outkicked your coverage, to use an American sports analogy, but at that point, then I would think, okay, maybe I want to reduce my training stress a little bit, but people, what they do during rehab is like, I'm kind of just going through the motions, not really training, and their training stress drops a ton, which, yes, it's going to drop fatigue, yes, you might feel a little bit better, but because also simultaneously your fitness adaptations are decaying.
You're conditioned to a certain extent.
Exactly, so then then you got to start, from the bottom, exactly, yeah, so I think, find your entry point, stick to the progression, don't get ahead of yourself. It's better to be a little more conservative than a little too aggressive, and then make sure that you're maintaining those fitness adaptations to the best of your ability, so that when you're back to unrestricted training, you haven't dug yourself a hole where you're like, I have no work capacity, no training tolerance, my cardiorespiratory fitness is trash, and like also
you're just going to put yourself back into that position all over again.
It's like regressing a training stage, and you got to start there, and wherever you start is where you start. So you gotta do that somehow. But those are the mistakes I see people make a lot. They don't take enough weight off the bar. Their progression is way too fast. And then if they do stop doing a lot of stuff, they stop training. Yeah. They stop training, and it's like, well, now you're a beginner again, which again is fine. It's just a longer recovery.
And then when they want to drop the load, how would you advise they do that? They just start warming up with the bar and see where they can go without being in pain, and then just stay there?
Yeah.
Or do they have to scale down to say 60%, 70, 65?
Sure, yeah. Like well, so it's interesting because we use RPE a lot, so on how to communicate the training intensity between a coach and the lifter. And normally in training, you're usually using RPE, reps in reserve, or even a discrete percentage. And a lot of when you're training normally, not in sort of a pain and rehab situation, the thought process is, can I add weight and still achieve this target, right? Can I add 5 kilos and it's still going to be an RPE 8 or something like that? In the rehab setting, that kind of shifts. Instead of can you, it's more should you. And so, for example, if you're doing sets of 10, 303 tempo, high bar squats, and you're like, can I add another 5 kilos? I'd rather revert that to should I, based on my symptoms and what I'm experiencing. I think, again, be more conservative overall, and kind of understanding that the 5 kilos isn't going to make or break.
Yeah.
And so you can be more conservative, find your entry point, progress, err on the, again, conservative side, and then you end up at a point where you're like, I'm not experiencing pain anymore, I'm desensitized, I've returned to restriction-free movement, now I can get, again, moving back towards this normal training, normal movement stuff. That's how I would do it.
And what would you say would be the case in case of a fracture? So I fractured my ankle maybe 14 weeks ago, and the doctor told me to stay away from training for 10 weeks, but obviously, I'm not trying to diss on the doctor, but he doesn't lift.
Sure, does he even lift, yeah.
Yeah, and he doesn't really understand much about resistance training, and I told him I'm on my feet almost all day because I'm a coach, and all of that. He's like, yeah, but you shouldn't train at all for the next 10 weeks. But I had fractured my ankle 3 years ago, so I kind of knew what the process was, and because obviously from all the research that we've read, we kind of know that you can still load other muscles in the leg. Like he told me not to walk, not to load my quads, not to do any kind of movement, right?
Yeah.
So what should a person do in this case? Like, do they listen to the doctor? Do they not? Do they go and find another doctor? Like, how can you kind of navigate around that?
Yeah, it's tough, particularly if a medical professional is giving somebody advice, because they've had the benefit of evaluating that person clinically, knowing their medical history, this, that, and the other, and sort of they have just more insight into that specific individual. Yeah. But from a general standpoint, I think if somebody has a fracture or other injury that immobilizes a single limb, to me, the rest of the body's still open for business.
Exactly.
Yeah, it's like just because the roller coaster's broke doesn't mean the theme park shut down. So you can do other stuff. And there's some evidence from different immobilization studies, single limb training, that there's like crosstalk. Yes, and that's probably best studied in actual strength performance and muscle cross-sectional area. But yeah, and we also know that there are obvious other health benefits to just maintaining activity as far as like time for recovery, because that's what people are thinking. They're like, oh, well, if you load the system, you're going to speed up recovery. There are multiple animal models showing mechanistic data that bone healing metrics, so there are various things in the blood you can measure, those things all increase. That's great from a mechanism standpoint. We don't really care about mechanisms as much as we care about the outcomes. So like, for example, does the time to union between the two bones, does that improve? Does the risk of non-union decrease?
The recurrence of injury.
Yeah, exactly. And all sorts of things, like is the bone mineral density better? Is the fracture callus more solidified? All sorts of things. And so unfortunately the data is just not really there at this point. The biggest signals we have come from elderly individuals after hip fracture that are randomized either to no exercise versus like exercising very soon, like days after the fracture. And they tend to do better. Again, these are more global ratings of not only like functional scores, so like sit to stand test, gait speed, stuff like that, and also pain, and then just quality of life. So my overall recommendation is that I don't know if exercise in and of itself is going to make the thing heal faster.
But it's not going to harm it.
Yeah, exactly. Yeah, the only real risk, and this is fracture dependent, depending on the anatomy, is if you are loading something that has not created a union yet. Yeah, you're at risk of non-union. And so my general recommendation would be like, let's keep the immobilized thing pretty immobilized, at least on that local area. But there are
the rest of your body.
I would. Yeah. Yeah, I mean, it's the same thing. What if you sliced your hand and you had stitches? Like, you could still figure out a way to train biceps probably, and triceps, and shoulder, and your delts, and legs, right? And so with an ankle fracture, it's tough because you don't want to immobilize somebody where they can't walk, or and so you probably had a boot or you had a crutch or both. And
no, I actually didn't. I just limped everywhere.
Oh boy.
The first time I broke my ankle, I had crutches everywhere.
Yeah.
And I put the full cast, like everything. But this time I didn't, because I only went and took an x-ray, I think, a week and a half after I had already fractured it, because I thought it was just a sprain.
Yeah.
But then I realized that the swelling wasn't going away, and
I see.
Yeah, all of that. It wasn't the smartest way to handle it, but like it's been 13 weeks, 14 weeks, and I'm back to squatting my old weights before the fracture. So I feel like if I actually follow the recommendations, so the first time this happened, I did follow a little bit more of the recommendations, and it took me so long. It took me a year
to get back.
Almost to kind of get back.
Yeah.
And this time I kept doing single leg presses. I did split squats. I did all of that. And then now I feel like I just kind of jumped back in. Yeah,
it's like the dose of exercise that you need to sort of maintain a good chunk of your fitness adaptations is relatively low, and you could figure out a way to do that without really messing with the affected limb. So, and then the last thing I'll say on this is that we know the risks of insufficient physical activity are high, not only from a health standpoint, but also just a healing standpoint. And so it would have to be a very serious medical emergency for me to recommend against exercise of all types. And I think maybe if you pressed the doctor, if you were like, so no exercise at all, not even upper body stuff, they'd be hard pressed to recommend against that. But in general, they're like, this woman is a power lifter. If I don't say anything, she's going to go
and do everything.
Yeah, so I understand their point, but it'd be very hard to recommend against exercise. Yeah.
Do you think there are actually any counterindications to exercise? What condition is there where someone like you are not allowed to exercise because this is this?
Yeah, so we get this question quite a bit at our seminars, and there are a number of medical conditions, all of which are medical emergencies that require immediate management, otherwise bad things will happen, where exercise would be contraindicated. And so the only time that you would tell somebody be physically active in the situation is if they were battling for their life and had to get to a secure location.
Okay.
So yeah.
It's not a condition, it's an emergency.
Yeah, exactly. So nobody has a chronic medical condition that is otherwise treated, or even something like a pain situation that is, again, not life-threatening, doesn't require urgent or emergent management, that represents a global contraindication to exercise, there are maybe things that you can or can't do just based on pain, for example, in an injury situation. But yeah, if you are actively in the hospital awaiting a surgical procedure or medical intervention, yeah, probably not a great idea to exercise. But my go-to is if you can walk unassisted, and if you can go to the bathroom unassisted, you at that point have shown me that you have not only the musculoskeletal integrity, but also the cardiorespiratory fitness integrity to do some sort of exercise. And you can scale that relative to the person's current abilities, what they have access to, etc. But other than that, nobody's walking around by themselves, living unassisted. That is complete contraindication to exercise. Yeah. There are a few heart conditions that people may have where the risk of bad things happening during exercise goes up, and those are individuals that have been told don't play sports, don't exercise, and this, that, and the other. And that is more of a personal decision, because every sort of physical activity raises your heart rate, raises your blood pressure, and none of them seem to raise your blood pressure or resting heart rate. So they all tend to be beneficial long term. Mm-hmm. But if you have a handful of these congenital conditions that we don't really have good treatments for, yeah, it's a risk, right? There are definitely risks to being insufficiently active for that person too, but also a higher than normal risk of being physically active, and they kind of have to weigh that. We had a seminar with this guy who he had a aortic dissection in his ascending aortic arch, and I read this on his little intake form, and I was like, dude, what are you doing here? And he's like, I'm a physician, I understand the risks. Like my doctor and I have an agreement that if something happens, I won't blame him. Yeah. But that's his whole thing, right? There are risks and benefits to everything, and so for him, the risk of being insufficiently active was outweighed by the potential benefits from exercise, not only on his condition, but also on his life, like quality of life and ability to age gracefully, extend his health span, limit his morbidity. So yeah, nobody, if you're watching this, nobody out there is living independently with a condition that is an absolute contraindication to exercise. They may not be able to do all of the exercises that they want or at the intensity they want, but yeah, it'd be very difficult to live independently without with a contraindication to exercise. You'd be in the hospital, you'd be awaiting some care.
And even if you're not living independently, or if you cannot walk without assistance, then maybe exercise is going to increase the probability that you will.
Yeah.
Maybe depending on the condition, I guess.
I agree. Yeah, I would agree with that. I think just the next step, if somebody's like, I can't ambulate unassisted, I don't live independently, at that point, that person is probably going to require some additional, not only surveillance and supervision, but also additional help just to exercise. But, again, if you're watching this, probably doesn't apply to that many people. Yeah.
Okay, moving on. Let's talk about genetic potential. So do you think there is a cap for how much strength or muscle someone can actually build? Like, we know that the progress slows down eventually the more experienced the person is, training age and all that. But do you think that someone is limited by how much genetic potential they actually have?
Short answer, yes.